Nitin Rathod, and he's going to take us through another hour of session on ECG. And not only he will be talking to you about ECG, but would also be talking to you how you can diagnose, and he would be also be talking about asking you certain questions, or he'd go through the quiz as well. Now, as I'm just trying to, basically educate you that today in the era of digital technology, one can ask the patient to take the ECG in his watch and send it across to the physician. So that we are able to diagnose rhythm disorders immediately. So there is a huge importance of ECG again in the digital era, and I'll welcome Dr. Nitin Rathod, who's a consultant medicine. He's MD in medicine. He's FRCP, and he's also has a lot of other degrees to talk on the topic, which is again very, very important, very dear to me. Welcome, Dr. Nitin Rathod. You can talk about for 40, 45, 50 minutes, and then you can discuss the chat questions. I had to attend a session, so I'll be breaking off, but definitely I'll be rejoining if possible. Right. Over to you, Dr. Nitin.
Thank you very much, Dr. Narendra Singh. Let us start. Good afternoon, everybody. Let us start our ECG quiz. Now, what I am going to tell you is the first.
Sir, can you put it in a slide, full slide mode?
Yeah, I am doing that. Hello.
Yes. Now, perfect, sir.
Yeah. Am I audible properly?
Yes, sir. Yes, sir.
Okay. So I am going to start a ECG quiz. And what I am going to show, I am going to show ECG first with the little bit history, 1 or 2 line, and then you can interpret, and then we can discuss further. Now this ECG which I have collected will be very useful for your ECG and for your DNB OSCE as well as on the Viva table. And not only that, if you are going to give MRCP exam, because I have been taking MRCP exam also, and we have been showing this type of ECG to them also. So let us start with ECG quiz number 1. See, now what I am going to tell you, this is the ECG number 1. Now what I am doing, the first 2 line is very important. Always read the history first. Whatever the history, from the history you will get a clue. And then you can go to the ECG quiz. Now what I am going to tell you do is, I am going to give 30 seconds to all students to interpret this ECG, and then we'll have a question and answer. Okay, 30 seconds is over. I can see in the chat I have seen that there are so many answers there, but majority of answers are correct. Sinus tachycardia, and I think the answer is sinus tachycardia. Now let us analyze this ECG. See, he is a 21-year-old female presented with vomiting and weakness. She is a pregnant. So now what will happen? This must be hyperemesis gravida. Now, hopefully that hyperemesis gravida, because of the vomiting, acid is out. Patient is having a metabolic alkalosis. So hypokalemia can occur. Some of you have given an answer as hypokalemia, but this is not hypokalemia. Second thing, because of vomiting, there is a hypovolemia, and hypovolemia always cause sinus tachycardia. Now let us go to ECG. Now ECG, see, now if you have this, you have to diagnose there is a tachycardia 1. Second thing is narrow complex tachycardia. So narrow complex tachycardia is nothing but sinus tachycardia or atrial flutter, or very rarely PSVT or paroxysmal supraventricular tachycardia. But now if this is paroxysmal supraventricular tachycardia, see here you can see clearly, see the lead 2. You can clearly see P wave, QRS, T wave, P wave, QRS, T wave. So typical sinus rhythm is there. On atrial flutter, you get a flutter wave, which is not there. Second thing, P on T should have been there if it is paroxysmal supraventricular tachycardia. So our answer is sinus tachycardia, and I must tell you, majority of the students are given a correct answer as a sinus tachycardia. Few of them have written a PSVT and hypokalemia. Okay, we go to next ECG. See, now again you have to read 81-year-old woman with palpitation and generalized weakness. And this is the ECG. 30 seconds I am giving to you for analysis. See, now 30 seconds is over. Now see, majority of you have given a correct answer, atrial fibrillation. And that is the correct. I am very happy at least you could identify atrial fibrillation. But your answer is incomplete. Yeah, some of them, Dr. Janvi Shah said that atrial fibrillation is fast ventricular rate. Yeah, that is the correct answer. Okay. So now again, you have to analyze 81-year-old woman, usually old age woman, palpitation, generalized weakness, maybe because of COPD and other thing. So now what I am telling is this patient is having analyze the ECG. ECG analysis is what? There is a narrow complex tachycardia which are irregular. So this is irregular narrow complex tachycardia, usually atrial fibrillation, flutter with the variable blocks, or some of them, some of you have written MAT, but this is not a MAT, but that is also one of the differential diagnosis. MAT is multiform atrial tachycardia. Understood? Now, why multiform atrial tachycardia is not there? Because patient and this ECG is not showing a P wave. P wave is now this become an atrial fibrillation straight away. Why it is atrial fibrillation? Because P wave is absent. P wave is replaced by small fibrillatory waves. If you see lead V1 and all, and most important thing is irregularly placed QRS complex. Irregular placed QRS complex. The diagnosis is atrial fibrillation with fast ventricular rate. Now, you must be knowing how to find out the heart rate in this patient. Can anybody tell me what is the heart rate in this ECG? No? See, now here you have to, sorry, here you have to find out the average heart rate. Now, how to find out average heart rate? Average heart rate, what you are supposed to do is number of QRS complex in 15 large square. 1, 2, 3, 4, 5, 6, 7, 8. 8 into 20. So almost 160. Yeah, this person is right. Shashank Rathod. He has written 160. Many people are writing 160. Yes, correct. The average heart rate you can say is 160. That is the correct thing. Now, can anybody see now? Rather than asking, I'll just answer you. What type of question you get it in OSCE is, this is a ECG, diagnose the ECG, complication of the ECG, or treatment of the ECG, or something like that. So now this is the atrial fibrillation. So you must know what are the complication can arise. One is atrial fibrillation with fast ventricular rate. Second important thing is, if the asystole period like this, if it is increased, patient can get a syncope. So atrial fibrillation with fast VR, syncope, repeated palpitation, patient can develop a cardiac failure also, and most important thing, embolization. Now for your thing, embolization, yes, that is a 15 to 20%. Atrial fibrillation is responsible for 15 to 20% of ischemic stroke. So that is the embolization giving rise to ischemic stroke is very, very common. Okay. So we'll go to next ECG. Again, you have to read the initial history. 58-year-old male with palpitation, lightheadedness, and weakness. Okay. So here also you have to see I am just giving you 30 seconds to interpret the ECG. Okay, 30 seconds is over. Now see what I am telling you, this ECG, as you know, this again this is narrow complex tachycardia, narrow complex regular tachycardia. We have already discussed whether it is a sinus tachycardia, no. Whether it is a atrial flutter, whether it is a, see now some of you have written AVRT, PSVT. PSVT is very unlikely here because you can see clear cut flutter waves. Can you see? Especially in lead 2 EO2C. Classically, here you can see classically in lead 3. This is sawtooth appearance. Many of you have written a correct answer is atrial flutter, but this is not a correct answer. Correct answer is 2:1 atrial flutter. Okay. So answer is atrial flutter. Now atrial flutter 2:1 block. Okay. Now, what I want to tell you is now how will you treat atrial flutter? So again, the symptoms is like atrial fibrillation. Second thing is treatment. Now in treatment, what you are supposed to do is flutter is better to treat rather than atrial fibrillation. It's very easy to treat rather than the atrial fibrillation. Now treatment is what? Rate control and rhythm control. This is how you have to answer. Don't give the name of the drug, amiodarone or beta blocker or ismololol or verapamil and all. Rate control and rhythm control. Now another thing is, if patient has come with atrial fibrillation with fast VR or atrial flutter with fast VR, what you are supposed to do is, if it is before 48 hours of or within the 48 hours of symptoms, then hemodynamically unstable, straightway go for the cardioversion by DC shock. Very good. And because I'm seeing the chat from these things, many people are writing same way. And if it is less than, if hemodynamically stable, then you can go for the drugs like amiodarone, ismololol, verapamil and all. And if you see the rate control. Understood? But if patient comes after 48 hours, then you are supposed to do heparinization, and ideally you are supposed to do TEE, transesophageal echocardiography, to see whether the clot is there. If the clot is there and hemodynamically unstable, give heparinization and then you can do. If there's a clot is there, hemodynamically stable, properly anticoagulate the patient. See that INR goes 2.5 to 3. Because moment you convert into atrial fibrillation to sinus rhythm, patient may throw embolization. To prevent that, this strategy should be followed. Okay. I'm very happy. Many people are answering that way. Okay. Now we'll go slightly difficult. 38-year-old man with severe palpitation and uneasiness. Now 30 seconds starts now. I hope I am audible to everybody.
Yes, sir, you are audible.
Okay, 30 minutes is over. 30 seconds is over. I am seeing a good response. Yeah. So again, this is what, again you have to analyze. Relatively young patient, narrow complex tachycardia, which is with a regular QRS complex. Okay, so regular as we have discussed, either sinus tachycardia, atrial flutter, or PSVT. Okay, now atrial fibrillation is not there because QRS complex is regular. Flutter wave is absent, then it is not there. So now remaining is PSVT, paroxysmal supraventricular tachycardia. The answer is correct. And if you want to go further deep into the paroxysmal supraventricular tachycardia, it is divided into AVNRT and AVRT. AVNRT is AV nodal reentrance tachycardia or atrioventricular re-entry tachycardia. Okay, so this is not AVNRT. This is AVRT. Why I am telling you this? See, even if you write in your exam, this is supraventricular tachycardia, nothing like it. Okay, nobody can cut your marks. But if you write AVRT, and then it is definitely they will make out that this student is definitely different than others. Brilliant student. See now why I am telling you, if you see P on T phenomena is there. P on T phenomena is always supraventricular tachycardia, what we call paroxysmal supraventricular tachycardia, if it is sudden onset. Now, what will happen? You see here, lead 2, 3, and AVF. There is a retrograde conduction of P wave. Okay, P wave you can see very clearly. That's why this is AVRT. AVNRT is nodal, but it is a larger wave, a larger connection or aberrant pathway from AV atria to ventricle, and there is a re-entrance tachycardia is occurring. Understood? So diagnosis is AVRT with, or we can call PSVT due to AVRT, atrioventricular reentrance tachycardia. Okay, clear? Now we go to next ECG. 65-year-old male with uneasiness and lightheadedness. Now your time start now. 30 seconds. Yeah, time up. Now see, majority of writing correctly, some RBBB, LBBB, pericarditis, inferior myocardial infarction, anyhow, and inferior with bundle branch block. See, now again you have to analyze is an old age patient. Okay, so old age patient may have ischemic heart disease. I am not telling that he has, but he may have. Now we start with the ECG analysis. If you see the ECG analysis, there is a tachycardia, heart rate is around 150 or something like that. Second thing is there is a broad complex. So this is a broad complex tachycardia. Okay, some of them is in WPW and all. Now just listen. This is a broad complex tachycardia. So with the regular QRS complex, if you see the QRS complex, so broad complex regular tachycardia is one is sinus rhythm. I mean sinus tachycardia with aberrant pathway. I mean, so not sinus, supraventricular tachycardia with aberrant pathway. Second thing is supraventricular tachycardia with bundle branch block, maybe LBBB, RBBB. And third most important is ventricular tachycardia. Okay, now if you see here, that first we analyze the thing and we'll see. Now the most important, see, I'll tell you the criteria of ventricular tachycardia to diagnose. One is presence of RS complex, which is absent. Absence of RS complex in chest lead. Second thing is presence of QS pattern in V6, V5, V6. Third, if there is a RBBB, then you should have a left axis deviation. If it is LBBB, then you should have a right axis deviation. These are all not foolproof criteria. The foolproof criteria, only one thing is AV dissociation. Okay. Atria, and you must see atria and you must see the ventricular contraction on ECG. So AV dissociation is the important thing. Another thing is if the QRX complex is more than 140, it is almost diagnostic of ventricular tachycardia. QRS duration. Okay, 140 millisecond. Now, if you see AV dissociation, see this is a lead 2. This is a broad complex tachycardia, and if you see there is a P wave. P wave is coming in between. You can see very nice P wave. So this is AV dissociation. Okay. So AV dissociation is a broad complex tachycardia, a regular tachycardia. It has to be ventricular tachycardia. Now, by definition, what is ventricular tachycardia? If you get 3 or more ventricular premature beat consecutively, then your diagnosis is you have to consider as VTEC. And if it is more than 30 seconds, it is called sustained VTEC, or if it is less than 30 seconds, then it is called as ill-sustained VTEC. Now, you must be knowing how to tackle the ventricular tachycardia. Now, before going into that, I'll just tell you. Next slide. See that this is a ECG criteria. See what I was telling is you can see the intermittent P wave. And the QRS complex is also regular, P wave is also regular. This is called AV dissociation. Now, second thing is, see, this is all premature beat, ventricular beat, and then this is called captured beat. Again, the ventricular. So, if presence of captured beat, presence of AV dissociation, and presence of fusion beat. Now, if you see this ventricular, and this is fusion beat. This beat is not like sinus, not like ventricular. So that's why it is called fusion beat. Understood? So your diagnosis is ventricular tachycardia. Okay, now we go to next ECG. 62-year-old female complain of retrosternal chest pain and lightheadedness. The time start now. It's very easy, and I expect everybody should answer properly. Yes. This become a spot diagnosis. You don't require even 30 seconds also. Who has written pericarditis? No. Majority of you, 99% has written correct diagnosis. Now see what ECG analysis says. There are changes in V1, AVL, lead 1, AVL, V1, V2, V3, V4. Okay. So your diagnosis is anterolateral, anteroseptal plus lateral wall. Anterolateral myocardial infarction, but you have to tell the stage, either acute myocardial infarction or you have to tell the proper stage like hyperacute, fully wall or old. So you can say either acute myocardial infarction, that is the correct word, rather than you can say hyperacute also. Okay, hyperacute, evolving and resolve. These are the 3 stages of myocardial infarction. So hyperacute and evolving we call acute infarct. Or if you are very pretty sure, say hyperacute myocardial infarction. Now, so your diagnosis anterolateral acute myocardial infarction or hyperacute myocardial infarction with reciprocal changes in inferior lead. 2-3 AVF is showing ST depression. These reciprocal changes always suggest that there is definitely myocardial infarction rather than pericarditis. Okay, now regarding myocarditis, regarding myocardial infarction, they can ask you, sorry, I have changed the thing. Yeah, they will ask you various questions. One is presentation. They can ask you what is, suppose if you are giving a Viva table, they will ask you door to needle time, door to balloon time. That you must be knowing. 30 minute and 90 minute. They may ask you what are the complication, early complication and late complication of myocardial infarction. Now, can anybody tell me early complications? See now, early complications are one, arrhythmias, embolization, cardiac failure. Then most important thing is cardiogenic shock. Next is what I want to tell you, important thing is cardiac rupture. Very good. Now these ruptures are various things. It may rupture into the free wall rupture, can cause cardiac tamponade and death. You can get a VSD. You can get the papillary muscle dysfunction. Okay. And you can get a pericarditis also. Okay. So these are the various early complications. PMD, papillary muscle dysfunction, is nothing but a mitral regurgitation only. Okay. Now, next is late complication. Now, late complications are shoulder end syndrome, Dressler syndrome, and most important thing is if the ECG changes persist for more than 3 months, you diagnose this patient is having a ventricular aneurysm. Okay. So this is one of the criteria of diagnosing ventricular aneurysm. Persistent of acute changes on ECG for more than 3 months, your diagnosis is ventricular aneurysm. Okay. Now we'll go to another ECG. Now see, the history is very important. 33-year-old female with intermittent episode of palpitation. She gets intermittently palpitation, otherwise normal. Okay. So if you see right now, the pulse rate is maybe 75 or 80. But history gives that patient is having an intermittent palpitation. So I'm waiting for 30 seconds for you to interpret properly. Okay, 30 seconds is over. See, I would say 95% or even more have given a proper answer, WPW syndrome. Okay. Don't write down pre-excitation. Straight away you have to say WPW or LGL. So you cannot say pre-excitation. Pre-excitation, you may get half marks. But your straightforward is, now why it is called WPW syndrome? As everybody said, short PR interval less than 0.12 second. Second thing is delta wave, or there is a slur on upsloping of the R wave, that is called delta wave, and broad QRS complex. See, in exam they will ask you, diagnose the ECG, criteria for diagnosing the ECG. Then they will ask you presentation or clinical symptoms. The fourth thing they will ask you, what is the treatment on this ECG? So this become your diagnosis WPW syndrome type B, not type A. Type A you get it in V1, V2. If you get a upsloping R wave, then you call it as a type A. And type B is V5, V6. If you see the V5, V6, upsloping R wave classically seen, so this become a type B. Now this is important to find out where the aberrant pathway is there. Then this you can do it with the help of electrophysiological study. Find out the aberrant pathway, and treatment will be radio frequency ablation. That is the permanent cure. Otherwise, if you want, you can give, if patient come with a WPW with fast ventricular rate, you have to control the rate with various drugs. But drug which control the AV node rate is contraindicated, because if you give the drug which block the AV node will get blocked, and the aberrant pathway will facilitate more and more conduction, and that will cause a deterioration. Understood? So this is WPW type B. And treatment investigation, I would like to do electrophysiological study. And treatment, I would like to do radio frequency ablation, or if patient come with a fast ventricular rate, I would like to give rate control drugs. Okay, we'll go to next. 27-year patient with occasional chest pain. See, occasional chest pain. $30 for you. RBBB. Okay, very good. What else? Hypertrophic cardiomyopathy. Very good. Next. Good. Many people are diagnosing properly. Now, diagnosis Brugada syndrome, not the hypertrophic cardiomyopathy. Brugada syndrome, not Torsada Pontis also. Okay, now come back to this. Let me analyze this. I am not going to chat. Okay. So your diagnosis, if you see the ECG, there is a V1, V2, you have a pseudo RBBB pattern. Now, what is pseudo RBBB pattern? RBBB, as you know, M-shaped pattern with ST depression with T-wave inversion. Now, here, if you see, there is a ST elevation and downsloping of ST segment with T-wave inversion. See, if you see ST elevation, downsloping, this is the differentiating point from RBBB, or what you call a pseudo RBBB. Okay. And now here also type 1 Brugada and type 2 Brugada. That I will show you, and then we can go into what is Brugada syndrome. See, this is a Brugada type 1 and type 2. Now type 1 is, as I told you, ST elevation, downsloping of ST segment and T-wave inversion. And type 2 is ST elevation, downsloping, but you get a saddle shape STT waves. Okay, ST segment and T wave. So this is called type 2. Basically, this is to find out where the aberrant pathway and other thing. Where is the problem? Not aberrant pathway, but where is the problem? And then you can do the further thing. Now, this type 1 and type 2 Brugada syndrome, they are sodium channelopathy, defect in sodium channel, familial clustering, and autosomal dominant. Okay, this is the autosomal dominant condition. And other name of this is called as SUND syndrome. SUND, SUND, sudden unexpected nocturnal death. Okay, sudden unexpected nocturnal death. Other name of Brugada syndrome is SUND syndrome. Now, as you know, name itself will tell you they may present with syncope, ventricular tachycardia, ventricular fibrillation, and one of the presentation may be death. Understood? So now we go for the treatment. What is the treatment? As soon as you diagnose patient is having a pseudo RBBP or Brugada syndrome, immediately put ICD, implantable cardio defibrillator. Okay, that is the treatment. Otherwise, you will lose him anytime. Sudden death is very, very, very common. Okay. So now we go to next. 34-year patient admitted to admitted for severe muscle cramp and weakness. Severe vomiting with muscle cramp and weakness. See now that this only gives the hint. Severe vomiting and muscle cramp. Okay, now 30 seconds is over. Yes, diagnosis is hypokalemia. Any other diagnosis? Hypokalemia, periodic paralysis. Atrial flutter? No, hypokalemia. Now see, as you see properly, you have to see the lead 2. What will happen? There is a P wave, QRS, T wave, and U wave. Again, the P wave, QRS, T wave, and U wave. So now what will happen? The U wave is same. U wave is definitely, yes, QT prolongation is also there. But the presence of U wave suggests hypokalemia. Now what will happen? The T wave slowly flatten out or sometimes inverted also, and you get a presence of U wave, and QT prolongation is there. So this is a classical of hypokalemia. Yes, you can see the U wave without flattening of the T wave also. It depends upon the potassium level. Okay. So now what question can be asked in this patient is, see, this is not a periodic paralysis and all. Weakness is not a muscle weakness. This is generalized weakness because they have written muscle cramp and weakness, generalized weakness. There is no limb weakness to tell it as a hypokalemic paralysis. Don't call periodic paralysis because we are not given any history of multiple times. This is a weakness. So even if it is weakness, we say that hypokalemic weakness. Now they will ask you what are the causes of hypokalemia. So as you know that GI, renal, this theoretically you should know all the things. GI causes is loose motion, enterosigmoid fistulas. Renals are all these patient on diuretic, renal tubular acidosis type 1, type 2, or hyperaldosteronism, Cushing syndrome, and there are many other conditions is there. And shift, patient on GI drip can cause hypokalemia. Patient with metabolic alkalosis can cause Gentleman Barter, yes. Lidl causes hyperkalemia, but Gentleman Barter also can cause a hypokalemia. Okay, so these are the various causes. And then treatment, or they will ask you which are the vegetables and fruit, which are the sources of potassium in the food. So you must know that coconut water, then soft drinks, then banana, potatoes, tomatoes, all fruits in fact. Okay, that's why all CRF patient we say that the fruits are not allowed because the potassium level goes up. So this is how patient can, and then they will ask you about the treatment. What are the treatment modality available? Okay, so this is a very simple ECG. We go to next ECG. See, if you see the history, you will get the clue immediately. 40-year-old female feeling weakness after missing dialysis. Now, time start now. Yes, times now I think from the history everybody is right. If you have not given history, you people would not have. I am very happy. Almost all 100% is given a hyperkalemia. But this is, I think, from the history. Okay, now history is very obvious, so you should not miss out this diagnosis. Now now come back to ECG criteria. Now see the ECG criteria, tall T wave. Now T wave is tall, sharp is there, but it is bigger than R wave. Can you see? You see the chest lead, T waves are bigger than R wave or even equal, but it is always see the lead 2 also. Bigger than it. So tall T wave, this is the definition. It should be bigger than R wave. Second thing is P wave become a flatten. PR interval increases, and then QRS complex also widen up, and then you can develop various arrhythmias and all. Sometimes the very difficult when you cannot understand any ECG, especially the wide QRS T wave, wide QRS T wave, one of the diagnoses is hyperkalemia. So you have to be careful for this hyperkalemia. And then again they will ask you, what are the causes of hyperkalemia? What are the presentation of hyperkalemia? And what treatment you can offer to the patient with hyperkalemia? The causes is same, GI, renal, shift of this thing, and plus tissue trauma like uh, rhabdomyolysis, acute tumor lysis syndrome, or you can get a crush injury where muscle releases lot of potassium or any major surgery. Of course, as I told you, renal is acute renal failure, chronic renal failure, and then hypoaldosteronism, Addison crisis, and there are many type renal tubular acidosis type 4, and lack of insulin, or what we call shift acidosis, lack of insulin, and beta blockers and all sometimes can cause this type of problem. ACE inhibitor and ARB inhibitor. Okay. Now, next is what treatment you can offer to this type of patient. Treatment is, okay, to calcium gluconate to neutralize the cardiac effect, but it will not reduces your potassium. If you want to reduce the potassium, what you are supposed to do is straight away you give GI drip. Second thing is you give soda bicarb. Third is potassium binding agent, resin or K binder or K bind, what we call classically. Fourth thing is what we do is dialysis. Okay. And nebulization with acetylene or salbutamol and all, beta adrenergic, it takes long. You require a very, very high dose to bring down the potassium. So actually, it is not advisable. Many people gives this nebulization and all. Unnecessarily, it will cause tachycardia and other problem. And it requires very, very high dose, so which we cannot physiologically give it to any patient. So it is theoretical thing, but not to be done. And if any problem is there, straight away dialysis. Okay. So GI drip. Second thing is soda bicarb. Third thing is straightway dialysis. If it is chronic, then you can give a potassium binding agent and other thing, K bind and other. Okay. Now next ECG. Now this is the same thing. See now hyperkalemia, I told you. There is a tall T wave, P wave is flattened up or P wave goes away, PR interval increases, and time will come when QRS complex also widen up and can cause arrhythmias. See now various electrolyte important for the ECGs. Hypokalemia, we have done it. There is a main important thing is U wave, hyperkalemia, tall T wave, hypocalcemia, you get a prolonged QT interval, okay, and prolonged ST segment, and hypercalcemia, short ST segment and widened T wave. These are the all important thing is there. Magnesium and all is not that important. Now we go to next ECG. 55-year-old homeless alcoholic male found lying on the road. Okay, 30 seconds I am giving you. Pericarditis, early repolarization, constrictive hypothermia, benign early repolarization, pre-excitation syndrome, hypothermia. Okay, what is QT prolongation, epsilon wave, fat, AIVR. Okay, now your time up. Now see, history will tell you lot of things. Homeless patient is something like a beggar type only. Alcoholic, found on the road. So and dehydrated, must be dehydrated, not eaten anything and all. Hypothermia is more likely from the history. But anyhow, you have to confirm with the ECG analysis. Now, what is the ECG analysis says? If you see the usually chest lead, V5, V6, V4, V5, V6, even lead 2, lead 3, and AVF is also showing there is a positive wave on the descending limb of the R wave, which is nothing but J wave, also called as Osborne wave. This is a very common ECG for MRCP exam also. Many times they write, many times they keep this ECG for your exam, OSCE type exam. And in our DNB also, we keep many times this Osborne wave. Okay. So your diagnosis is hypothermia. Am I audible? So your diagnosis is hypothermia. Okay, now so you must know what are the causes of hypothermia or which are the other conditions, or we can say that differential diagnosis for this ECG is or are. One is hypothermia, hypocalcemia, hypokalemia. These are the various things where you get or QT prolongation sometimes can create a problem like this. But this is a differential diagnosis. I am not telling you about diagnosis. Diagnosis is very straightforward. Hypothermia, presence of Osborne wave. Now let us see, this is a simple ECG. How many of you get a diagnosis on this? 56-year-old male patient, sudden onset breathlessness. ECG is given below. 30 seconds start now. Pulmonary embolism, okay, next. Pulmonary embolism. Sinus tachycardia with this pattern. Pulmonary embolism. S1Q3, PTE. Okay. See, majority of you have diagnosed, majority, I would say up till now, almost all have diagnosed S1Q3 T3 syndrome. I am very happy. See, now this patient, as you know, sudden onset breathlessness. Sudden onset breathlessness is very few causes. One is pneumothorax, second is pulmonary embolism, and third is left ventricular failure, or very rarely bronchial asthma. Okay. So now in this patient, if you see properly, there is, as everybody is diagnosed, S1, Q3. S1 is deep S wave in lead 1, Q wave in lead 3, and T wave inversion in lead 3. S1, Q3, T3 syndrome. Now, in addition, what are the other findings? Patient is having, if you see, incomplete RBBB. In addition, sinus tachycardia. Okay. Now, these are the various common cause of this thing. Now I'll tell you one USMLE question was there when we used to when I appeared in 1997. What is the commonest changes in pulmonary embolism? Can anybody tell me what is the commonest ECG changes in pulmonary embolism? The differential diagnosis was RBBB, RVH, P pulmonale, sinus tachycardia, or RVH with strain pattern. Yes, diagnosis was very correct. You people have given a proper answer. The commonest changes is sinus tachycardia only. Okay, so we don't expect. This is called classical change, ECG changes of pulmonary embolism. If they ask commonest changes of pulmonary embolism in ECG is sinus tachy only. Good. Now, can anybody tell me what are the investigations? See, now if this ECG is given, they will ask you, diagnose the condition. What other investigation would like to do in this type of patient? Or so, as you said, D-dimer, yes. Second thing is we will do X-ray chest, 2D echo, and third most important diagnostic test is contrast induced pulmonary angiography or CTCE. Okay, CT scan contrast enhanced pulmonary angiography of the chest. Okay, so that is the diagnostic. Now, what treatment you can offer to this type of patient? 5 modality of treatment one must know. One is anticoagulation, that is heparinization. Second is thrombolysis. Third one is IVC filter. Fourth one is catheter embolectomy. And fifth one is surgical thrombectomy, means open up. This is a desperate attempt to save the patient. Majority of the time patient will die if you do the surgical thrombectomy. But first two option, and at the most sometimes we have to go for the third option, that is IVC filter. Okay. So now we go to next ECG. I think we are running short of time. Okay. Okay, now just this is the last ECG. We'll finish it off. Now, 50-year-old woman reports 2 hours of left chest pain followed by syncopal episode. Morbid type 1. Okay. Morbid type 1. Why morbid type 1? First degree block, third degree block, second degree block, complete heart block. Good, at least you know that there is a bradyarrhythmia. Okay, 30 seconds are over. Okay, so left-sided chest pain followed by syncopal attack. Syncopal attack you get always whenever there is arrhythmias, that you know. So this become a bradyarrhythmias. And if you see the ECG, there is a RBBB. Okay, so there is a RBBB. Now lead 2 is given in the bottom. Now see, this is a P wave. P wave. P wave is followed on T wave. That's why T wave configuration is changed. Again P wave. Now see, the P wave is fallen between the QRS and T wave. So now when, see, this is how you have to suspect complete heart block. If P wave is falling on QRS, before QRS, after QRS, and altering the T wave and other thing, your diagnosis is complete heart block. So what you are supposed to do is take pen and paper and just chart the P wave, P wave, P wave. So this missing P wave you will come to know. Okay, this is the P wave. So that P wave will come on the equation. Now this P wave. See, the P wave is coming in between the QRS and T. Now this is P wave. P wave. Now P wave is fallen on T wave. That's why T wave configuration is changed. Again P wave. Now see, P wave is fallen just on the R downsloping of the R wave. Okay, and then QRS you have to measure. That is also equal. So 3 QRS you chart and just roll the paper here, it will be same. Okay, so your diagnosis is complete heart block of AV node. Now, what treatment you can offer to the patient? Suppose patient is having a 60, 70 BP and pacemaker is not available. What will you do? Till the pacemaker is available. Pacemaker is not available. Temporary pacemaker is not available. See, BP is low. So what? Sorry. BP is not available. I mean, pacemaker is not available. BP is low. You have to use dopamine. Dopamine will cause increase the BP and not dobutamine. Only dopamine. Dopamine will cause tachycardia. So dopamine is the correct answer. Okay. If BP is maintained and around 90 and all, you can try with atropine. Atropine may not work more majority of the time if the complete heart block is there. So dopamine, if there is a bradyarrhythmia and hypotension, otherwise ideally you are supposed to do isoprenaline will not increase the BP, not very useful for increasing the heart rate. But dopamine you can try. Meanwhile, the procedure of choice is pacemaker. Okay, you have to do the pacemaker thing. I think we are getting, my time is getting over almost 1 hour. They will create a problem. Okay, now if any question, I think we question and answer we have completed during the ECG session only. But however, if you have anything, just let me know. If any question is there, I am ready to answer. Otherwise, what we can do is, you can just write to me. I will just answer it. See, now this question, let me tell you one thing. This ECG, in a majority of the ECG, I have seen selected for even MRCP exam also. I am a MRCP examiner also, so I keep many times this type of ECG to them. And of course, DNB we keep, but even MRCP we get many times of this. Some one student is how many large boxes, sir, for the rate calculation in atrial fibrillation. Atrial fibrillation, you have to count the average heart rate. 15 large square into 20. So you have to find out how many QRS complexes are there in the 15 large square. Multiply by 20 will give you heart rate per minute. Okay, this is how you have to calculate average heart rate. Any other question? If question is not there, then we'll finish the presentation. If any question is there, you can just write to me. I will answer them.
Dr. Nitin, I hope you are able to see the chat box.
No, I am not getting any visual. Am I audible?
Yeah, loud and clear.
Yeah, yeah.
Now open the chat box at the right bottom.
Yeah, chat box is already open.
So scroll down, there are a few questions.
One of the candidate has written AVRT and AVNRT ECG changes. I already told this, whatever I have told you that 2-3 AVF if showing a retrograde transmission of P wave, then AVRT. And if you have a young female, usually without any structural abnormality of the heart and sudden onset and sudden abrupt termination also, we always suspect AVNRT. If you want to confirm, you will have to go for the electrophysiological study. And then you can go for the radio frequency ablation to have a permanent cure. One candidate was asking, can we discuss rhythm abnormality alone in separate session? We can do that tachyarrhythmias in one session. Tachyarrhythmia is very important and very straightforward thing and very useful for the practice also. How to identify atrial flutter? You have to see the flutter wave. Sawtooth appearance, whenever you get a multiple sawtooth appearance, that is a flutter wave only. You can very clearly see that sawtooth appearance. In myocardial infarction, there is one candidate written reversal changes seen in what aspect of the lead. If you have a anterior myocardial infarction, you will get an inferior wall reciprocal changes. If you have an inferior myocardial infarction, you do get a anterior wall reciprocal changes. Kindly clarify Brugada syndrome in detail. See now Brugada syndrome, whatever possible thing is there, we have done it. And then you have to go for the, once you diagnose pseudo RBBB, straightway, you have to go for the ICD, implantable cardiodefibrillator, to prevent the sudden unexpected nocturnal death. In complete heart block, if hemodynamically unstable, can shock be given? Yes, that is the procedure of choice. If patient is having hemodynamically unstable, then this is choice is straightway pacemaker, not the shock. DC shock is not going to help. I thought you have written a DC shock. I mean, pacemaker. Pseudo RBBB, I have already told you what is pseudo RBBB. Is a presentation like M-shaped pattern with ST elevation instead of ST depression. That you get it in Brugada syndrome. Ventricular tachycardia, I have already told you the criteria. The diagnostic criteria is AV dissociation. You can get a captured beat, you can get a fusion beat, and QS pattern plus LBBB with right axis deviation, RBBB with left axis deviation. QRS is more than 140 millisecond is diagnostic of ventricular tachycardia criteria. See, how to differentiate between early repolarization and acute MI. Early repolarization, what you will get it in acute MI, you get a coving, convex. And if you get a concave ST elevation in early repolarization, that is how you differentiate. And of course, you will be given a history also. The patient is asymptomatic if you get like this. And usually you get it in V1, V2, and ST elevation will not be very high like myocardial infarction. It will be either 2 millimeter, 3 millimeter, not more. This MI with LBB, these are all different criteria, not in this lecture, because unnecessarily it increases the timing and all. One day we can take a lecture on this thing. LBBB with primary T wave changes in myocardial infarction or ischemia. I think we have covered everything. And if even still it is there, you can write to me. I'll just reply to you. Sir, can I end the lecture? I'm ending the lecture,
Yes, sir.
winding up the thing. Okay.